Melissa.
Morning.
How are you?
Good. How are you?
Good. Thanks for having such a wonderful idea for today. I think it's going to be great.
Yeah, we'll see how it pans out.
I mean, we'll see, but I think it's going to be good.
Okay.
I'm optimistic.
I appreciate that. Thank you.
Yeah. We'll wait a little while for people to float in before we get going. So
Sure, not a problem. I do have some slides to present.
let
And
me
then,
make you a co-host so that you can share.
okay,
There you go.
thank you.
Cool.
Yeah, so I'll just wait for you to give me the go ahead. And I assume we'll do introductions to start.
Yeah, we'll do the usual,
Yeah.
like wait for people to kind of trickle in and then do the introductions, and then I'll just turn it over to you, and you'll have the whole 90 minutes. Well, minus whatever it takes us to do introductions.
Sure. Okay.
Cool. Awesome.
Thanks.
Thank you.
Morning.
Morning.
How are you feeling this morning? You ready?
As ready as I can be, sure.
I will help you facilitate discussion however you need. So I think this is going to be a really nice experiment. I'm really excited you proposed this. So I'm kind of looking forward to see what kind of discussion we generate.
Yeah, I am taking an approach I've taken in class with regards to just like critically thinking through the idea. So we'll see how it pans out, and I'm open to feedback.
Definitely. This is great. So
Yeah.
I'm excited. I have such mixed feelings about this. I go both ways for a lot of different reasons. So I think it's really going to be, I'm hoping, a really good discussion.
Yeah, that's why I kind of like the topic, because it's a mix of emotions and feelings with regards to it. So yeah.
Agreed. Agreed. So thank you.
Yeah.
Chris, we need to change the date on that slide.
Yeah, we do. Going back in time, apparently. I wish it was just July. Wait just a few more minutes so that some more folks have a chance to trickle in, and then we'll get going.
Chris, did you hear from Saoirse about doing a substance use presentation or case presentation?
Yeah, I did, and I asked her if she wanted to hold off and present next month instead.
Perfect.
So, but yes, I did, and I was very grateful for that. Well, I think we can probably go ahead and get started. And I'll let people in as more folks arrive. I think just like we normally do, we can go.
Oops, you just muted yourself, Carissa.
I was trying to unmute my video and I muted my microphone. Hello, everyone. Thanks again for coming. We'll get started. We can go through and do introductions just like we normally do. Today we have more of a, what will hopefully be more of a discussion rather than a didactic and a separate case presentation. Melissa is going to lead this. She'll share some stuff with us, but then hopefully it will be more interactive with everyone and give folks a chance to really dig into some interesting topics. So I will pass it off to Piper to introduce herself, and then we can kind of popcorn.
Excellent. Thanks, Carissa.
Yeah, for sure.
Piper Meyer-Kalos. I am an IRT clinician at SLP and one of the PIs on the EpiNet project. And I will popcorn to Melissa Dalhoe.
Hi, I'm Melissa Dalhoe. I'm a clinical social worker by background and program director of the Navigate program at the U in St. Louis Park. And I'll pass to a team member, Orly.
Good morning, folks. I'm Orly Haven, family clinician at the Navigate program in St. Louis Park, and I will popcorn to Amy. Good morning.
Good morning, everyone. I'm a doctoral student working under Piper, working in the Navigate team, doing some IRT. I will popcorn over to Claire.
Thanks, Amy. Good morning. I'm Claire Moser. I'm a C at the Hope program at Hennepin Healthcare, and I will popcorn to Elizabeth.
Hi, I'm Elizabeth Habish. I'm an IRT on the Hope program staff here at HCMC. And I'll give it to Marielle.
Good morning. I'm Marielle Demery. I am the program director of the Hope program and a family clinician as well. And I gotta look to see. I will pass to Kayla.
Every time, literally. I'm Kayla Polson. I am the program supervisor for the Child and Family team and the team lead for the FEP up at the Human Development Center in Duluth. And I will pass to Liz. Did Liz go?
Hi, I'm Liz Breen. I am the director of the Cedar Rapids, Iowa Navigate team. And I was a little late, so who hasn't gone yet? Anyone?
How about Lindley?
Yeah.
Thank you.
Hi, I'm Lindley Broughton. I'm the case manager with the HOPE program in Minneapolis, Minnesota. I will popcorn to Andrea.
You're still muted. There you go.
There we go. Okay.
Yep.
I'm sorry. I'm Andrea Botsit. I am a marriage and family therapist in the Department of Psychiatry at the U of M. Hi, everyone.
I think we've got Danny.
And then I'm Danny. I'm the C, so Florida Educated and Employment Specialist at the HOPE program. And I think that's it.
Nope, we got a couple more. Cece?
Oh, yep. I'm Cecilia, IRT clinician at the Human Development Center in Duluth.
And Saoirse.
I'm Saoirse. I'm the IRT here at Hennepin Healthcare HOPE program.
And Vic, we're doing quick introductions, just who you are and your team.
Hi, I'm Vic, and I am the peer specialist on the HOPE team.
Excellent. I think that's everybody.
Yep, that's everyone. Thanks, guys. Welcome. It's great to have you all here. So I mentioned earlier, there's a bunch of people that have joined since then. Today we have something a little bit different, which is that rather than doing like a separate didactic followed by a case presentation, we're hopefully going to do something that's a little bit more interactive, more of a larger discussion, and the case presentation components will be kind of woven throughout. And Melissa has graciously volunteered to lead this today, and I'm really excited, and I hope that you all feel able to contribute as much as you want to or are willing to the conversation today. So I have given you sharing capabilities, Melissa, so whenever you are ready, you can take the floor.
All right, thank you, Krissa. Yeah, so like Krissa said, I'm gonna do a little bit of a presentation, but hopefully weave in a lot of discussion, so as you're comfortable participating, but you'll hear me talk for the first part of it. So I'm gonna share screen. I have some slides here. I do notice I lose you when I share my screen. Is everyone able to see it? And if you're nodding your head, I can't see you.
Yeah, can't see it.
So we can't
not see it.
We can't see it.
Okay.
All of us.
I'm gonna try again here. Share screen.
There we go.
Now we can see it.
Okay.
Yep, now it's working.
Is it in presentation mode?
It is.
Yes.
Awesome. Okay. All right. So this topic I proposed, I'm calling to mandate or not to mandate substance use treatment. And as you know, one avenue in which we try sometimes to mandate substance use treatment is through like commitment proceedings. And here I'm going to present an alternative, which is considering the use of behavioral agreements specifically for our FEP teams, which is why we're here, right? So I also am proposing that this is a critical thinking exercise, and I'll kind of describe a little more about what I mean by that. I am not here to say behavioral agreements are the right way, and definitely not here to say they're the easy way. But when we think about critical thinking, it's the intellectually disciplined process of actively and skillfully conceptualizing, applying, analyzing, synthesizing, and evaluating information gathered from or generated by observation, experience, reflection, reasoning, or communication as a guide to belief and action. And so what do I mean when I say a critical thinking exercise? So instead of presenting the way to do things, which is the use of behavioral agreements in this instance, I'm looking to just present a concept, an option that has essentially been proposed to me and my teams for you all to conceptualize and then apply to a patient scenario that is familiar to you. So I'll invite then everybody to engage in a discussion analyzing the approach of using behavioral agreements, where we'll discuss essentially the pros and cons to the approach based on your observations, experience, reflection, reasoning, in hopes to guide your belief and action as it pertains to your case scenario. So I like to comment on this graphic because I chose it because literally depicts the various ways in which we might conceptualize decisions we make. And for behavioral agreements in the context of substance use, I want you to think as I go through presenting some of the information, as you apply it to a case scenario, what would be easy about it? What would be hard about it? Is there a right way, a wrong way? If you go up the poll here, there's this way, that way, new way, old way, and I'm not quite sure what the top is. It's too blurred out for me, but really wanting to critically think through this. So perhaps it depends on your perspective, right? And so I want you to think about that. What is your perspective? Are you client-centered? Are you engaging in shared decision-making? You hold true to a harm reduction approach? Are you a professional acting in accordance with professional values and ethics? Are there ever exceptions to any of these perspectives? And if so, under what conditions? So I'll come back to some of these questions, but just want to introduce you to what I mean by critically thinking through what it would mean to use a behavioral agreement with a client. So therefore, the objectives are to understand the challenges to treating psychosis that FE teams face with when substance use persists, which I think we know, but just to kind of set the stage. Also to understand how to apply the use of behavioral agreements to enforce treatment recommendations specific to substance use. And then, like I said, critically think through and discuss the use of a behavioral agreement in a patient scenario or case example that's familiar to you. I always like to weave in a little interactive polling in presentations these days. So I'm going to toggle screens here. Let's see if this works. Can we see this instruction slide? Oh, maybe it's loading. Does this show up for folks? Okay.
Yes.
If you are not familiar with Mentimeter or menti.com, it's an interactive polling platform. You can join on a web browser, on your phone. You can QR code this to enter it, or just go to the website, enter the code. When you do, if you could click the little heart, I think that'll help me gauge, if most people are connected. Just wanting to ask some questions and get a sense for what we're bringing into today's space. Okay, I think that's about everybody. Okay, so I'm going to start us out here with a couple questions. This is a scaling question, just asking how, or actually hold 1 second, because this was not meant to be my first one. I'm going to delete the slide. Apologies here. Okay, let's start over. This is just to make sure everyone's connected, just wanting to gauge across. I know we introduced ourselves, but what is your role in treating individuals impacted by psychosis? Just want to get a feel for where we fall on the spread here. Awesome. Okay. So, oh, good, lots of variety. All right. This next question, just wanting to pull, have you encountered challenges in doing your work effectively due to a person's ongoing substance use? It's all what kind of brings us here. So a little bit.
I love the dog.
Yeah, yes. Yeah. Great. I have some more questions. How do you feel when someone you are working with continues to use and it interferes with treatment progress and or goal attainment? This is a word cloud and you can enter maybe up to 5 different words. Just wanting to know like what emotions resonate with you. And as people with a word cloud, as people choose the same exact word, obviously you can see there's some variations with like frustrated, frustration, but if people identify the same word, it's a larger font size. So I can see like discouraged really stands out, frustrated, sad. Yeah. Yeah. I'll just give another minute here if anyone else wants to add. Yeah, I think concerned, defeated, helpless. Absolutely. Right, wanting to help. We want to help, but often we feel stuck, right? Great. I'm going to move on to our next slide, or polling question, I think. How much do you disagree or agree with the following statement? If only I could require someone to go to substance use treatment. Ah, interesting. Well, we'll see how you like this topic. It'll make for good discussion, if anything. Great. Thank you. Have you heard of behavioral agreements before?
A+ gifts, Melissa.
Thanks, Orly.
Yeah, your gift game is strong.
That's the fun part of it. Okay, wow, I wasn't expecting as many people to be familiar with behavioral agreements, but that's great. So I won't spend a whole lot of time just defining what those are. So you've heard of behavioral agreements, a lot of you. I'm curious, have you used or discussed the possibility of using a behavioral agreement with someone directly? So have you talked with a patient or family or, support person about, a behavioral agreement? Okay, good. So we'll have a good mix. All right. And I think that's the end of my polling questions. Thank you for participating in those. I'm going to go back to sharing my screen here. All right. So this is not going to be new information, but again, I think it really helps set the foundation for why are we talking about behavioral agreements as even an option. So when there's persistent substance use, as many of you know, there are challenges for us as FEP teams. And this is just an overview of the challenges teams face when substance use persists and patients aren't actively engaged in or not wanting to work toward engaging in a treatment program. So persistent substance use hinders treatment outcomes with regards to symptom management, working toward goal and value directed behaviors. They can also interfere with actually delivering the Navigate FEP material when substance use takes priority. Diagnostic uncertainty remains in the presence of substance use. A lot of times, substance use presents safety concerns from a physical and emotional health perspective. Substance use can interfere with engagement, whether that be not attending appointments or attending them under the influence. Providers manage their own reactions, as do patients. Providers manage their own reactions to client substance use. And like we saw a report feeling stuck, for example, and all those emotions from that word cloud. Concerns for provider liability often pop up in the context of an inability to adequately meet someone's needs. And then I want to comment that with regards to community resources, like where is there a psychosis and substance use specialty program to refer to? I think there are often challenges in trying to find a resource that is going to accept a client into their program, but also one that's going to be both psychosis and substance use specific. That's not in our community anyways that I'm aware of. And then there are also challenges with petitioning for commitment from the community, let alone for substance use in general. So I'm going to talk about behavioral agreements, just kind of introduce them and then invite you to apply. Recall, we're going to critically think through the topic. So first, we'll conceptualize, I'll present the background and purpose of behavioral agreements, then we'll apply. I'm going to invite you to think of a case example familiar to you and guide everybody in applying the use of a behavioral agreement to that scenario. And then we're going to discuss and analyze. I'm going to open us up for a discussion on the pros and cons of using behavioral agreements to mandate substance use treatment, specifically on our FEP teams. All right, so to conceptualize. First, I like to provide a little bit of background on like, how did this topic even come up? Navigate patient scenarios are often present where patients are not following treatment recommendations and the level of care patients are engaging in was not meeting their needs. So we're often feeling stuck, providing less than adequate level of care on an outpatient basis to people who are acutely ill for a variety of reasons. They may say they want to work with us, but only in whatever, only maybe in an outpatient capacity with weekly visits, and they decline our recommendations for a higher level of care, for example, or engagement with our program is just overall poor as substance use interferes with engagement. And so we have lots of questions that were coming up where, okay, well, if this person isn't engaging in our program and they're not following our treatment recommendations, how do you even broach the topic of terminating care with a patient and what is required? More specifically, what do you do when someone's not following treatment recommendations, putting themselves and others at risk? Maybe you're feeling liable, and yet the person doesn't qualify, for example, for an inpatient hospitalization under a 72-hour hold. Can you terminate care if someone's not following treatment recommendations? And if so, under what circumstances and what steps need to take place? So had some discussions with our legal and risk management, and they were like, oh yeah, behavioral agreements. And I was like, interesting. So I see pros and cons, and I'm looking forward to hearing your pros and cons. But I just want to introduce first what the guidelines of a behavioral agreement are at my organization, and that's University of Minnesota Physicians. But I'm going to read this because I think it's just well laid out in that a crucial element of patient care is a consistent, safe, and stable relationship between the patient and provider. Healthcare providers and staff may encounter difficult, disruptive, abusive, or non-compliant patient, family member, friend, or caregiver behaviors at times. These behaviors create challenges that can compromise the patient-provider relationship and impact the provision of safe and effective care for the involved patient, and negatively impact other patients, visitors, and employees present in the care environment. When these circumstances exist, the provider may ask the patient to enter into a behavioral agreement that identifies the undesirable behavior by the patient and or family member, friend, or caregiver, and details an action plan to support positive behavioral change, thereby attempting to establish or reestablish a healthy patient-provider relationship and provide a safe and welcoming care environment. If the defined behavior change is deemed absent or insufficient, there is a potential for the patient to be terminated from our care. So this really, I think, sets us up for some of the language that was proposed to me that we could use with individuals when introducing behavioral agreement. There are some assumptions that I kind of want to throw out there. And this too was discussed with legal and risk. First we have to ask, are we dealing with someone who's able to make their own decisions? So we're going to assume for today's purpose that people are decisional. And risk identified just simply stated that just because you have a mental illness doesn't mean you are incapable of following treatment recommendations. So really we want to evaluate, is this person decisional? Today we are going to assume they are in our case examples. Second, we have to be of the professional opinion that ongoing substance use is problematic, and the team is of the opinion that the person's needs cannot be met without substance use treatment. If we're going to mandate it, we need to all agree that the person needs it. And third, I threw in like petitioning for commitment, again, for the purpose of today's discussion. Petitioning for commitment is either not an option or has been unsuccessful in the past. So I'm just going to describe a little bit about some of the expectations or the workflow in a way in which we would think through implementing a behavioral agreement. Some things need to take place first and what I call give fair warning. But generally we have the right to set expectation and boundaries around care. So we want to consider how much is the patient directly being told, these are the expectations. And if the expectations are not met, or we're not able to optimize the patient's care, we may have to seek care elsewhere. It has to be very clear. We have to be having both components of the conversation, which is what the expectations are and what if the expectations are not met. So the moment, which I think about a lot now since having these discussions with risk, the moment we take a patient on our FEP teams, we are saying we have the ability to care for this person. And so if at any point we feel we aren't, we want to be communicating that with the person and talking about what maybe in addition is needed or what in replace of us is needed. Individuals should receive written expectations. They should also receive a warning before a behavioral agreement is considered. And so after satisfying number 2 and 3, we could move forward with a behavioral agreement. I was given the suggestion to consider a welcome kit. I'm gonna put a plug in. Marielle at Hope Program and her team has I've seen a beautiful welcome kit. I think there's room for improvement on my teams. And so this, I think, just emphasizes the importance of setting expectations from the very beginning and doing so in writing. An example with the welcome kits that I was given was, again, it's all in the essence of we care about the people we serve. We want them to succeed. And in the effort to do so, then we lay out our expectations. And so those expectations might be something as simple as if you cancel X number of visits, or if you cancel a no-show, we'll move toward a behavioral agreement. And if you don't follow, then you'll have X amount of days to transfer care elsewhere. And so we, at our organizations, we have, and it's important to be familiar with your organization's policies around kind of things like no-shows and canceled visits, but a behavioral agreement is sometimes something that results as somebody no-shows or cancels frequently and isn't engaging in care. Other considerations I just want to throw out there. Oh dear, that's my dog. I apologize. Other considerations are if we're going to be setting expectations and if we're going to be considering a behavioral agreement, we want to be clear with documentation in the chart that this was discussed verbally and what those expectations are. And like I said, know your institution's policies and consult with your legal risk folks. For UMP specifically, we're asked to follow up with our legal risk department for help in drafting a behavioral agreement. And they talk about some of the regulations or policies around, at a minimum, you have to give at least 30 days to transition care elsewhere. If a patient declines to follow recommendations to transition care elsewhere, you could say you have, for example, 60 days to make a transition, and after that, we'll not continue to see you. So your organization may vary in what those timeframes are. So be familiar with those. All right. We're going to apply. So this is where I want to guide everybody in just thinking through a case example that's familiar to you. And I'm going to make some suggestions around maybe what type of case example you choose. And if you want to take notes as we go throughout, certainly feel free. Otherwise, after we kind of walk through this and generate some thoughts internally, we'll share them externally. So wanting you to think of a familiar case example, and I have some suggestions. for ease of exercise, I'm suggesting you consider an 18-year-old who's their own decision maker. Again, we're assuming they're decisional. They have the capacity to make their own decisions. But I'm suggesting 18-year-old because they can make their own decisions. And when you think about your role, I recognize that depending on your role on the team, your discipline, you might not be the one introducing the behavioral agreement. Maybe you are, or maybe you're a team member who's just reaffirming the use of a behavioral agreement to mandate substance use treatment. Examples of concerns that I think would be helpful or that I'll walk through for this exercise is thinking that substance use is active and contributing to ongoing psychosis and or other mental health symptoms and functional impairment. And so the idea is that we as a FEP team, we're trying to treat psychosis. We can't treat psychosis in the context of problematic substance use is really what we're getting at here. Another thing that comes up is arriving to appointments intoxicated. That could be an example. I'll provide some language around what using a behavioral agreement for that would look like. Also, say we recommend substance use treatment and either the person's declining to participate in evaluation and subsequent treatment, or has done an evaluation and is declining to follow those recommendations or some modification of those. So I want you to think of a case example, and I'm just going to give us a little bit of time here to mull over some of these questions, which is, and again, here's another assumption, but is the FEP team meeting the patient's needs? I mean, the assumption is no, because if we're meeting the patient's needs, then we're not going to do a behavioral agreement. So wanting to make sure that applies. But I also want you to think about what are all the needs that are going unmet? Might this just look like unmanaged psychosis? Maybe there are, and kind of going to the next question, what are the risks of ongoing substance use? Maybe it's escalating suicidal thoughts. And so safety is of a concern. And then, like I said, we as a team want to be on board on treatment recommendations. So, in your case example, think through what are the overall treatment recommendations? Is it to work with our FEP team and a substance use treatment program at the same time? Is it to transition to maybe a substance use program altogether? And then think about, with regards to those treatment recommendations, what can the FEP team treat and what falls out of scope? So I know substance use is part of some of our IRT modules, right? But if someone, say, has a Rule 25 assessment, which is in Minnesota, a substance use assessment that results in a recommendation for an appropriate level of care, what if the recommendation is for residential treatment? All of a sudden, that's falling out of our scope, right? And for what is out of scope, what is the recommendation? So again, it gets back to treatment recommendations. Is the recommendation that, we need you to just do an evaluation and see what recommendations are, or have you done an evaluation and now there are treatment recommendations to follow through with? I also encourage people to think about, how does substance use evaluation treatment recommendations align with the person's goals and values? I think this really gets to the introduction to a behavioral agreement, which is, we care about you, we want to help you succeed in your treatment. And so I know, and you can kind of beef that up and say, I know that your goals are A, B, and C, and this is how these recommendations align with that. You can really personalize it a little more. So I just want people to jot down some thoughts. I would like to just wait, maybe give a few minutes here. I might have one more slide though. Let's see. No, I don't. Let's just take a few minutes. I'll watch the clock. Think through some of these questions. Think of a familiar case example. Really put yourself in the position of interacting with the person. I'm going to then present some approaches to which you could actually, and language you could use with somebody. And I want to make sure we set the stage for you to evaluate whether or not that fits, if it feels comfortable, uncomfortable, and why. So let's just take a few minutes here and jot down some thoughts. We'll just take another minute. All right, I'm going to kind of move us through, now that you have your familiar case example, move us through what it would look like to introduce a behavioral agreement as it's been proposed to me. And so again, as I walk through these approaches, I am really inviting you to think about what would work with this approach and what wouldn't work with this approach. How would it be helpful? Maybe how would it be harmful? And so I want you to the best of your ability, think of both sides. Okay, so when introducing a behavioral agreement, the overall approach here is we want to say, again, this is just kind of encompassing the whole definition of it, but we want to say we are here and these are our expectations. And these expectations, like I said, are dependent on what we think is reasonable. But we're saying to the person that we need you to do these things because they will help you help yourself. They will help us help you. And so some thoughts to think of when you're thinking about, okay, what setting am I going to bring this up in? I think that's important to talk about. And one consideration is to consider this as part of the treatment planning process. So start with talking to the patient, you know, we are here to be supportive of you, and this is the plan. Our treatment recommendations are as follows. Or if concerned that this is needs are falling out of scope, we believe at this point, we do not feel we are in the position to adequately address all of your needs. And our plan is to get you into one of these other programs, and this is why. And the recommendation is really to optimize your care. If the person is unwilling to follow recommendations, then we introduce a behavioral agreement. So let's assume, again, another assumption that the person is like, well, I don't want to do that program. So When first I want to suggest some language around, let's say the person is showing up intoxicated for appointments. It's clear they are admitting to it. And we can't do the work we want to do with somebody or our job if somebody is intoxicated. And so maybe a behavioral agreement is being introduced to say that, we can't have you, under the influence during appointments. So the language we might use is, and we want to be very straightforward. You cannot be intoxicated for our visits because it's not productive or an effective use of our time or your time. If you come to an appointment intoxicated, we will assess safety, but then we'll end the visit. We will then look toward implementing a behavioral agreement. And then you can move into talking about what a behavioral agreement is. I'll get to that in a second, but I want to introduce the other common scenario, which is that the person is needing an evaluation and or treatment for substance use. So here we might say, or we could say that we're willing to work with you on this. We want to see that you're making efforts. We'll work with you if you run into roadblocks, but our expectations would be that you're making strong efforts with the intent to enroll in a treatment program in the next 60 days. 60 days is just an example because let's say you want to gauge it upon like, is it reasonable for them to get an evaluation and be enrolled in a program in 60 days? Or might it take longer? So you want to set a reasonable expectation. Then you want to go on to say that if you continue to demonstrate behavior that's counterproductive, we would consider the use of a behavioral agreement or dismissal from the program. And so then it's like, all right, what is a behavioral agreement? So this is some of the language that was suggested to me, which you could explain. And so a behavioral agreement is a written agreement between you and the clinic or the team that documents that you are going to follow through with our recommendations if you want to continue care in our clinic. We use it to level set what our expectations are moving forward. If you are making strides after today's meeting, enroll in a treatment program, do not come to appointments intoxicated, great, then we'll not use a behavioral agreement. And again, this is about giving fair warning. But if you do not comply with recommendations, we will pursue a behavioral agreement. When one is in place, again, if you make strides, follow recommendations, great. If you violate the agreement and expectations, it means we could dismiss you from our program and you'll have to seek care elsewhere. So I hope that you're able to kind of try that on in your patient case scenario, because now what I really want to do is open us up for discussion and critically think through this, really analyze the pros and cons. So I will stop sharing my screen in a moment, but just some questions I invite you to think about is, I first would like to have us talk about what are the pros, because I think it's easy to poke holes in this. But first I want to start with what are the pros to behavioral agreements? How might a behavioral agreement be helpful in your case example? How have behavioral agreements been helpful when introduced to somebody in your experience, if you have the experience? So we'll start there. And then I want to move into what are the cons? And I might put these questions too in the chat, but how might a behavioral agreement be harmful to somebody? How might it misalign with your professional values and ethics? I think about that as a social worker. How might a behavioral agreement misalign with the Navigate model, for example, which I was mulling over and found interesting. And so I'm going to stop sharing screen. I'm going to put these questions in the chat, but really want to open us up for discussion on, what do you see the pros of behavioral agreements in your case scenarios? And maybe as you participate, if you could give a little background on, this is a patient who was coming to appointments intoxicated, or this is a patient who needs substance use treatment and has been declining. A little context I think might be helpful as well. I'm kind of experimenting here, so also let me know if you have questions. I'm gonna stop sharing. Okay.
I can jump in. with some pros. So reminder, I'm orally family clinician with Navigate, and I'm thinking of a specific example where a behavioral agreement was actually implemented. So this was a young person whose use made it so that they showed up for their appointments intoxicated. And in addition to that, during like the rest of their lives, when they weren't visiting with us once a week, they were putting themselves in a position to be very vulnerable. In fact, they did get taken advantage of in very significant ways. And additionally, they had suicidal ideation very significantly, and subsequently suicide attempts did occur in the context of heavy use, in this case of methamphetamine. They also used a motor vehicle while intoxicated at times. So, you know, a major pro in this instance, we all had very significant concerns about personal safety for this young person for very obvious reasons, but also public safety in the context of the use of motor vehicles. So it was a really frightening prospect kind of all around. So major pro was just addressing acute and like clear and present safety concerns. And after implementing the use of the behavioral agreement, this person did actually comply, has maintained sobriety from that particular substance, has not been driving intoxicated and endangering the public. This person also did get into, thankfully, a injury causing motor vehicle accident while intoxicated. So that danger was reduced, and they have not had any suicide attempts, significant reduction in suicidal ideation overall, and is no longer in vulnerable situations being taken advantage of by others. So safety concerns have been reduced so dramatically. It's honestly like myself and the IRT are no longer having like near tearful consultations weekly about our fears for this person. So like on a personal level too. Awesome. I also appreciated, I mean, the symptoms that the substance use would contribute to was a significant barrier for this person to have any meaningful engagement in the IRT, you know, in the actual like treatment of the symptoms we are here to treat. So like scope and our roles was really difficult to actually carry out in you know, the context of the substance use. That got much easier once the behavioral agreement was implemented. Efficacy of treatment has improved. Adherence to medication has improved. You know, reduction of symptoms of psychosis, distressing symptoms of psychosis has happened. It's a singular example, but there's some really significant pros there. Maybe later on I could share some cons too, but I'll let other people talk now.
Thank you, Orly. That's a great example because you touch upon so many aspects of, I think, the concerns that come up on our teams, right? About not just the person's safety, but our reactions, how we're feeling about this, as well as, you know, what this means for symptom management, impaired functioning, all these things. So I really appreciate you sharing that example. And I'm curious, do any of those pros ring true for others? Or are we just like boo behavioral agreements? Do we not like them? This is why I start with pros first.
I like them because I think it's really clear to the person, right? Like you're laying out, this is what we are asking of you. And it helps people, I think, make informed decisions too, of whether that's something that they feel that they're able or willing to do. I would say, I think they work really well when they can be collaborative. So like presenting here the things that I think would be really helpful. But maybe I've thought of something that that person just feels like that's unrealistic for me right now. And so kind of making some of those modifications. I can't think of any examples of my own, like doing that recently, but I know as a team, we've got a couple of people in mind. So I don't know if other people want to jump in with those examples.
I'll comment to being familiar with the case that Orly referenced. This individual, it was recommended as a result of the substance use assessment that they engage in residential treatment. We collaborated, not we, I mean they, the team collaborated with the person to discuss, well, what is it that you are willing to do? Well, they were willing to do an outpatient version of the program. The program was willing to admit them and enroll them in their outpatient program, with the caveat that if this isn't working, we need to consider a higher level of care. So we really tailored the behavioral agreement around that. I also want to comment that often with behavioral agreements, they usually don't come about until we've exhausted all our opportunities. That is also an assumption that I should have included, because the point of a behavioral agreement is really to almost like get a hold or get a hold of, what's going on. And it really, I think, depicts that the prior situation was just, again, like we tried everything, and behavioral agreements are usually the last option.
There's a case from when I was on this team from a little while ago where we did not a written behavioral agreement, but we had very clear communication throughout the case, to where she did get a Rule 25. The recommendation was residential. She wasn't open to doing that, which was also our recommendation. We were to the point where we were like, we are not meeting your needs. She was doing super inappropriate things, like she snorted a line of Coke during our visit. So what we did, though, is what she was in client-centered approach. She said that she was open to an outpatient option, which ended up being an ACT team. But we essentially said, okay, well, you have X amount of time to do this to get involved with this outpatient and like stay with the FET program. If you don't meet that by this time, we are moving forward with referring you to an ACT team, which is eventually what happened. So in that plan of giving her a date to follow up, because there was this feeling of like liability and care in this case, where like we were not appropriate. Like if she got substance use care and we were going to give it a shot, we were willing to give that a shot, but she didn't follow up on the outpatient substance abuse care. And so by that date that we had set, we referred her to an ACT team, which did successfully have an admission. So that plan worked out really well. And that was a big pro, I think, for that situation.
Mm-hmm. I think you bring up a really great point of when it works out, it's definitely a pro of behavioral agreements. I think it's when you move into the scenarios where the person's like, all right, well, I'm not doing an ACT team either. And then you're forced to discharge someone from your care and they go in the community untreated because that's their choice. I'm getting into cons, but you can kind of see how it feels like a pro, especially when things kind of pan out. But we see a negative side too sometimes.
And we had considered that in this case too, and that would have been extremely unfortunate if she did not sign a release for us and did not agree to go to an ACT team. Actually, I wouldn't say she was like completely agreeable, but it happened. So like that's great. Agreeable enough for that. But we did consider that like this might happen. But I think because of that liability, we had given the recommendation. She was still able to make her own choices. And so we had given her sufficient time. We had given her those boundaries of time frames. And so I think I was at a place that if that's what she chose, it didn't feel great, but I think we had done what we needed to do and we knew we were not the appropriate service for her anymore.
Yeah.
So one of the things I think is kind of interesting here is, and that can come up if you think, how does this align or not with the Navigate model, is that we cannot be everything to everyone. And I think what you're really talking about is decisions about what is our scope of practice as a Navigate team. And what I'm hearing from these examples on the pro side, at least, for this, is that these are really hard, but really fair decisions to say, this is our, Melissa referenced, obviously, there's a whole module in IRT about substance use problems. We're not naive to assume that people coming into this program, that if they use, they can't be treated in the program. That's not the assumption. What we're saying is that we're also not a residential inpatient or intensive outpatient even level of care. And we don't have that expertise. We don't offer that kind of training, and we don't have materials. And so I think one of the pros here is that that is considering that scope of practice, and where does the person start to step out of what is considered our scope of practice as a Navigate team. So just saying, it's an interesting way to think about it.
Yeah, I'll add to that, because I think what can happen, what I've seen happen, is you're working with somebody, you care a lot about people, and sort of head down this slippery slope, right? Where you keep trying to meet them where they're at, and then kind of all of a sudden realize, like, ooh, we're really kind of stretching the limits of what our scope of practice is. And in that sense, I think behavioral agreements can be a reminder to the teams as well. Like, these are the constraints of what we are actually capable of doing. And so it just provides that clarity so that there isn't, I mean, I know, like the example that Elizabeth gave, we had so many conversations about, is some care better than no care? Can we provide that some care? And we've had that conversation with other people, not just about substance use, but with like eating disorders and a whole host of other things. So I think it just helps bring clarity to sort of everybody that is a party in that person's care.
I guess I have a question or comments. So I know for the C role, we have done some like wellness agreements with people, which I think have been really helpful. And it's more not just focused on substance use, but like someone's going back to college and we're bullet pointing IRT skills, supports on campus. And that has been, I think, really effective for some people to bring together IRT, coping skills in a one. And it's, I think, really a positive thing versus like a behavioral plan, more of like, this is what your wellness will look like, and just confirming that you're going to continue to do that. So I don't know if like that would be associated with the behavioral plan, if there's only one specific thing in a behavioral plan versus multiple pieces. But I think that has been a really great approach to like bring different like every single kind of someone's whole wellness together. And like one of them did talk about like taking medications and like not overusing substances, but that wasn't like a single, like a big concern for either of their, like for sure one of the persons. So just want to like throw a comment about that. And that's been a really effective tool, which I know is different than the behavioral plan, but just another very similar framework.
And if I'm understanding you correctly, Claire, thank you for that. I think about the model we've implemented for treatment plan meetings, very much come together as a team, but highlight strengths, goals, wellness. This is all in the vein of wanting to help somebody be well and taking that team-based interdisciplinary approach. And so I think that is a really great option. I would probably assume from an organizational perspective that would precede a behavioral agreement. You know, a behavioral agreement would, if that didn't work, you could go down the route of behavioral agreement. But I like this option as a sooner option that precedes behavioral agreements.
In this kind of like wellness agreement that Claire is talking about, I think it really yeah, I think it certainly could precede any behavioral agreement that needs to happen when that's presented. But I also think that this is really an opportunity, and what we've done that to like point out like essentially the negative consequence, the like natural consequences that could happen kind of if wellness is not taken care of. Especially in like going back to college, like when people are, especially when they've come to us after having, you know, failed a semester of college and they're coming back into their semester, we want to support those goals. And like, you know, I think there have been times when people have gone back to college and we're like, we'll see what happens. But but this wellness agreement, the way that we've used it is kind of a way to be like, these are the things that we all agree are things that can keep you well. And essentially the understanding is kind of, if they don't happen, there is this risk and this chance for these natural consequences. You know, whether that's becoming unwell and having to go back to the hospital, whether that's, you know, not being able to finish the semester, like those aren't things that we are going to like maintain and set boundaries for, but the risks that could happen in that way. And then if things are where it could be a precursor is kind of like if things start kind of decompensating while they're at school, that might be this opportunity to be, well, let's now talk about a behavioral contract.
It's interesting because in this same case, there is an element of substance use. So I've started to an intermittent engagement. So it's been hard to even have this individual in a session to be able to start the conversation of at what point would we do a Rule 25 assessment? And at what point do you feel like, you know, even if I wanted to quit the substance, I couldn't. So we kind of started that conversation at the same time. We had like a joint visit with this wellness plan. So this was interesting timing for this topic because I was just pondering the substance use piece of this and how to approach that. Yeah.
Well, I want to make sure we have ample time to also discuss the cons of this because I think there are obvious ones and there are many. And so I did put these questions in the chat, but I don't know, I try to, when I introduce different models and things like that in the classroom, I really encourage students to think about like how things are helpful, how things are harmful, the pros, the cons. And so it's not that we have to accept everything as it is in one form. And so I want you to think about how might this be harmful to somebody using a behavioral agreement, but two, like, how does it misalign with your professional values and ethics? I think that comes up a lot for people. I think about social workers and the right to self-determination. And two, how does it misalign with the Navigate model? We've talked about collaborative, you know, shared decision-making. And so if anyone wants to expand on those or offer other thoughts, that'd be great.
I mean, I think the obvious thing is the personal autonomy and right to determine one's own life, right? And a behavioral agreement is sort of a dictation that we are placing on somebody. I also, though, really think a lot about, you know, what stage of change the person is in. And so if there is a degree of ambiguity or just like straight up, nope, I don't see anything wrong with using this substance. What we all know about substance use treatment is if a person is not ready to change, they are not going to change. So a really challenging aspect of a behavioral agreement that says, go get a Rule 25 and follow it is what's that going to do if that person is not ready for the treatment. That doesn't negate, like, you know, the like being outside of scope and safety concerns and all these other things that we mentioned before as pros, but it is significant. Sorry for jumping in front of everybody.
Well, and I think it makes it even more difficult too when there aren't safety concerns, because I feel like there's a level of responsibility when there are safety concerns, but like you had mentioned on one of your slides, like kind of like if these things aren't met, then you know, discharging from our program. But with some people like who could benefit from a behavioral plan, like I don't necessarily feel like I'm ready for them to discharge from our program. I have like a couple of individuals in my head that like marijuana is a big barrier for them, but it's not a safety issue. It's getting in the way of their recovery, 100%. But it's not a safety issue. And like, you know, can we continue? Like, I feel like we can absolutely continue the Navigate program as we're doing it. The effectiveness of it is, I think, going to be in question. But I think that could be a con if like it's always like, it's this or nothing. Like I think if there can be ways to have more gray area in the kind of the consequence of the behavior agreement. I like it's actually making me think a lot about this one individual who like wants to stop marijuana for work, wants to do that on his own, but like hasn't been able to. It's been his goal for like 6 months now. And he hasn't been able to do it. And I'm starting to think actually maybe this could be doing a behavioral agreement with him could be helpful in the way of like, not like, okay, we're going to be done with you. Because I think that would be a huge con here. I don't think that's appropriate. I don't think that would be good care for this individual. I think the best care is to stay with our program right now. But, you know, maybe it's like, we're agreeing then to actually talk about this and you're going to bring it to IRT or to see like what, if it's specifically for work, like, I'm wondering if that actually could be a positive, but then I think the other con of that is potential disengagement. When that happens is like, if somebody is not ready and they're in this contemplative place, and then you're trying to like say, okay, we made an agreement, here we are, we're going to do this agreement. Then I think we risk that disengagement from the individual.
Yeah, so I think the rapport component comes up a lot for therapists, especially, but I think all roles, because we're all building rapport, but there's always this concern of like, well, if I bring this up, it's going to break rapport. But I want to go back to something you said, Elizabeth, about, well, it's marijuana. What comes up a lot in these conversations is this, it brings up this question of what's the threshold for when you introduce a behavioral agreement? Is it applicable to all substances? What level of substance use? And how problematic does it need to be? Which is why I kind of lean on the concept that the whole team's got to be on board with like substance use treatment is necessary in order to do our job, in order for the person to, you know, be on a path to wellness. But it's a great point. There's a lot of gray area, especially when you think of like what type of substance is being used. And what do you do if someone's using multiple substances? Do you pick and choose? Is it all or nothing? It's complicated.
I can jump in too to go off, kind of extend what you guys were saying too. I agree with, you know, a lot of what I'm hearing. For me, from a kind of my own personal approach, it can feel very punitive to me, and so that's where I really kind of struggle, because I'm not the police, I'm not your parent. It's not so much the rapport. I mean, of course, the rapport is affected by it. You know, this is a collaboration in my practice. It's not that punitive approach. But the other piece, and I've been in this field for a long time, what I've really found is that being very careful about how we hold those boundaries and expectations. I love that a behavioral agreement can clearly communicate those expectations and the concerns. But at the same time, when we're saying, if this can't happen, you need to, you know, get the assessment, the Rule 25, you need to go to treatment kind of thing, that provides an expectation, I think, within the provider as well as in the patient or the family, that treatment is the cure. I just go to treatment, 28 days later, I'm all better. And that just really isn't the reality. That substance use treatment is not a magic cure for anything, you know, going off of that. So I just want to really be careful of what expectations we set with it. So I think behavioral agreements are beautiful when used in this gray area, like you're talking about, Elizabeth, recognizing that this is not the do all end all, that, you know, so that's a really careful piece I would have. And I think in behavioral agreements as well, one more thing of that punitive approach. Another con that I have found with it is when the behavioral statements are utilized in the terms of, you know, you need to do this, you know, you need to, you know, whatever that structure is, those you statements, you know, in therapy, you can be a very shameful approach. And especially coming from a family therapy perspective, oftentimes what I find, not oftentimes, historically, I have found multiple times that kind of language for kids really will step things back of, you're my parent kind of thing of like, you need to do this, you need to do that, and can actually kind of trigger some trauma responses as well. So I'm just saying there's a level of caution that needs to occur.
I was gonna say, I think it'd be interesting to look at behavioral contracts and like who people we support get them. Is it like Black individuals? And has that been part of their, like, have they gotten pulled over by the police or have a record because of like their race? And are we continuing this pattern of we have to put these expectations as a white female team? And I think being really aware of that and how family and trauma and like everything, if that's a coping skill, I don't know. I think that'd just be something to be really aware of, like, is this fair across the board? And of course we would want to implement that way, but just understanding, just like when someone comes to us and already has been discriminated against, what we can do to change that for them. So.
Oh, I love these points with Andrea and Claire. Something that comes to mind for me too is a lot of people come to us with so much, like on one hand, despair and need and crisis, and they just kind of look to us for so much support. And so to also say, okay, well, you also need to do these things, or else. It feels like that or else for me type of language, I think can be re-traumatizing as to what their experience was, maybe even trying to access care. They came to us thinking, oh, here's a program that's going to help, and now this program is saying we can't. I think we do have to be very careful about language and do it in a trauma-informed way.
This is such a good discussion. It made me think of a client that I've been struggling with just in general, and the area about where do you go if you've got somebody who's using multiple different substances, but at different levels of change within those substances. And yet they also are not willing to take advantage of the treatment that's being offered. So the treatment that you're providing to them, that you're saying, I'm here, we're willing to do this, we're willing to talk about this, and the person's presenting this distress around this area, but then goes back and continues to use the substance to avoid everything, to avoid all of that's the main coping skill. And it feels like you're stuck in this catch-22 of substances are still continuing problematic, continuing to increase risk, but not the risk that you're talking about, not using in sessions, not going out and using with motor vehicles kind of stuff, not the safety stuff that we're talking about, but this ongoing circle that happens of, I'm going to come in, I'm going to tell you things are really bad, I'm feeling a lot of distress, and I'm saying I'm willing to work, and then next week it's like I can't do that. It's avoidance. It's and it's like, so we go back and how many times do you do that? How many times do you repeat that cycle? How many times do you say, okay, I'm presenting this cycle to you, and like, what do you make of this? Where do we go from this? What's the next step for this? This is this weird, gray, strange area that's caught up in different substances, different levels of change, high use of avoidance, trauma that is there, sometimes wants to be addressed, sometimes not. Very, very complicated.
Yeah, I think of several points. So one is kind of to your point, kind of on the success of these agreements. I think of therapy homework. And if you assign homework that somebody's just like not realistically going to be able to do, then you're not helping that person. And for a behavioral agreement to be successful, it has to be something that the person has the capacity to do. I think it's also important to kind of highlight something you said a while ago, Melissa, that these agreements, like, this is the last ditch effort kind of. I mean, this is after having exhausted every other possible way of trying to engage a person effectively in care. And I also think that a really effective behavioral agreement has expectations of both the patient and also the clinician. So, here's what I am going to do. So if it's somebody who's like really struggling to like get to sessions on time, just as an example, right? Like I as the clinician am willing to call you an hour before that appointment and to remind you of that appointment. And the expectation is that you are arriving on time so that we can do this work together, and then having like a time frame of let's reevaluate this plan in a month, see how it's going, see if we need to make any changes. Because it would feel really punitive to just say like, well, you just need to show up on time, versus this has been a barrier to our work together. So how are we going to like make some of these changes so that you can be successful?
I really like that, Marielle, and I think we try to do that in some of our behavioral agreements, even if it's just around, like sometimes we've had to do behavioral agreements around just like language and behavior and appointments and or communications with staff. And we try to use language that talks about like expectations and requests of the person, but also what can you expect from us? It's a two-way street. It's not we're going to impose all these things on you and they aren't going to apply to us type of thing. So I think, you know, seeing both perspectives is helpful.
Additionally, I'd like to suggest a third direction, or recall family clinician here, and just thinking about how often in relation to substance use, the family perspective is, you know, sometimes a bit myopic and also very, very fraught with legitimate like concerns and emotion, right? Like parents don't always get and shouldn't always get much insight into the content of the individual therapy and what we do, but parents and other support, you know, members have really significant concerns. And I'm not sure that I've fully, I definitely haven't fully wrapped my head around how to actually address that every time it comes up. But that, you know, for those of you on this call that work with family members, it comes up every time, and it comes up again and again and again. And I'm thinking of the behavioral agreement that I actually referenced earlier. That family was so happy that we had this behavioral agreement implemented for the young person who had been using meth. And also that family has a bit of a passive approach to things and had an assumption that that was going to fix everything, right? And that is not necessarily the case. This person is absolutely complying. Safety concerns have plummeted in like a really positive way, and that person remains extremely ambiguous. They're not at all convinced that they like needed it, even though they were complying with it. And I think there's a significant possibility of future use once substance treatment is completed. And I think it's going to be very interesting how the family interacts with that possibility of future behavior, like reverting to old behavior. Yeah.
Hey, thank you for bringing up the family. I was kind of waiting for that because we're an FEP team. We have family component. And so this is something we have to think about. We often, I know in some examples from our teams, have family members who are like, you have to make them go to treatment. They have to go. It's the only way. And so you say, okay, and I think for one might be this case, presented a behavioral agreement to a patient, and the family either heard about it just after or were part of that visit hearing about it from the IRT. I think that was the case. And they were like, you're just going to drop them? You can't do that. You can't. And so it's like, okay, how do you balance and manage like families' requests to mandate treatment, but also that fear of what if they don't follow through and maybe disenrolled from the program and that type of thing. And I'd love to see and hear about a family case example at a future echo clinic if anyone was open to that.
I wanted to go back, Melissa, you had said something about like kind of if we're doing these agreements and like having said like we can help you, but this discouragement that could happen from the client's point of view of like we said we were an appropriate level of care, but then like it ended up not being that. I just want to give a shout out and kudos to Marielle, because I think she does a really, really lovely job in her intakes, in kind of taking what she's seeing and being like, we're going to give this a shot, but like this could be the outcome. And there have been multiple times when Marielle is very upfront and honest in that first initial visit, which makes it really easy for me then to go back and have those conversations if I need to have those conversations. And so just kudos with that. And to you, Marielle, I think it works really, really well. And there isn't that then necessarily this promise of care. We're going to see what happens. It's an option that this may not be a fit. And if that's the case, we will go from there.
Yeah, and I would similarly add, we make it really clear to people, like, this treatment is also their choice, right? So if it is a fit, this is something that you get to choose. We get folks that come to us on commitment, and we're really explicit that just because you're on a commitment doesn't mean that you have to do this program. We had one time a person actually wrote into the commitment paperwork the HOPE program, and I raised hell, and I was like, that's got to get out of this paperwork, because that's not okay. People should still have some choice, even when they have legal requirements to do some sort of care.
I want to recognize we have 5 minutes left. I don't know how we want to wrap up or anything like that. Maybe any comments? Was this helpful, stimulating discussion? Did you like the format?
I'd love to hear that, how people like the format. This was something I thought was a fantastic idea from Melissa. So I'd be very curious how people like the format.
I really like the critical thinking exercise of what's good, what's helpful, what's harmful. I also like the interactive polling.
I second. I loved the interactive polling. And I appreciate discussions like this too, when they're able to happen.
If folks think of other topics they'd like to do this, and maybe we can even nudge Melissa to, I think she was great at facilitating this discussion, but if there are other topics too, in addition to behavioral agreements, that we think an interactive discussion like this would be very helpful, let us know. Chris and I are doing our best to get to the areas that people are most interested in, bring the right people in. But I thought this was a great way to facilitate this discussion. And I think there's true pros and cons here, definite on both sides. So yeah.
Yeah, and I think it's just important to remind everyone that comes that the purpose of these is really for it to be collaborative, and so while we are doing the work behind the scenes to find people to come and have these discussions and get these case presentations, that's fueled by what you guys are indicating are areas that you want to have discussion. And so if there are things that are coming up in your work or questions that you feel like we haven't addressed or ideas that you have, we really want them, because that's the whole purpose. And so I was really excited about today because it is different, and it was an opportunity for people to really kind of be more talkative, right? And be more engaged. And I think that going forward, I would like to do more of this. So because I do think even when we say, oh, it's not just a didactic and a case presentation, and we really want you to interact, when it's set up that way, it's harder to interact. And so not intentionally not setting up that way, I think gives people more of an opportunity to contribute. So really and truly, if you guys have ideas, throw them out there. No idea is too wild, because that's the whole point of this. You guys can go and listen to training seminars all day long, any day, anywhere. And that's not the purpose of this. So please don't hesitate to shoot me emails with any topic that you're interested in. So, or any ideas you have about what might be useful.
I want to throw out one idea for the family component, because I wonder if it would be helpful to do even a collaborative presentation where multiple people might present an approach, and it would be an approach to maybe the topic of when family requests and expectations do not align with the patient's preferences. I think that comes up a lot. Orly has a super great drive the bus metaphor that I just love. And so I think about how she could share that, and if other family clinicians or others have like a strategy they could present and we could try on and discuss, might be interesting.
I like that idea. Yeah.
I have a different topic that I have no expertise in from a clinical standpoint, and would love to see if there was more discussion possible. And that's the intersection of autism and psychosis and how it interacts with, you know, the Navigate model and what the hell we do about it.
Yeah.
Yeah, that's a good one.
Really good point. And I will be, we'll need to kind of, I want to ask around. So if you know anybody who knows a bit about autism and psychosis, pass that along as well. But otherwise I can reach out to my networks as well and see, but it's a great topic and something inevitably all of us have dealt with, all of us, I guarantee it.
Yeah.
Amy Murray might be a quick option if.
Good idea. Chris, if you'll write that down.
Yep, I'm typing away as we speak.
Well, I recognize too, we have 1 minute left. I just want to thank everybody for participating in the discussion and just kind of sharing your experiences and pros and cons. I know that it's not always easy space to be in, disagreeing with, say, a presentation topic, but the whole point was to generate some discussion about how we disagree with this. So thank you for being here and for participating today.
Yeah, thank you all so much. We'll see you in a couple weeks.
Thank you.